So the first talk I'm going to give here is sort of on the question of creating value by avoiding complications. Complications are really terrible, and they're a reality, unfortunately. And many of you may have read Atul Gawande's book, Complications. There's a whole bunch written on this. I'm the vice chair for quality and safety at my institution, and so I am very interested in this. And a lot of this is going to be in the context of Codman and what Codman did in terms of measuring outcomes more than 100 years ago. So the title of this is Creating Value, Avoiding Complications, and Using Registries, Measurement, and Experience to Allow You Critical Introspection so you get better every day. And I'm going to focus this principally on arthroplasty. I could do it in anything. And specifically the complications that make you suddenly stop, take your breath away, or wonder if you should call a lawyer. And so these are fractures, vascular injury, humeral fracture, nerve injury. And I'll also show an extra credit case if you're interested. That is kind of interesting. So, whoops. Okay. So I'll talk a little bit more about this, but most of you in your training, if you're like me, wonder, what you're doing there, and will feel somewhat like you're an imposter at some point. And then unfortunately, you'll get very confident, too confident, and then you'll have a problem, and then you'll regrip and try to understand where you are. I have some conflicts here. I'm going to talk about one in particular, which is what's called Blueprint, which is a 3D planning program tool. And I have a conflict of interest with it, just to warn you on that, but it can be very helpful in revision cases, as you'll see in a minute. So I assume you wanted me to talk about things like this because you think I have wisdom, and wisdom is a confusing thing. Wisdom is actually not the guy that looks old here, but it's a perspective that comes from learning from failure and knowing the right questions to ask. And that'll come up in the next lecture too. Questions are more important than the answers. And experience allows you to have critical introspection, and having a good network saves your butt frequently. Just the other day, I was asked to go to the OR and help somebody. So I like to say I'm in my sweet spot. That's where I'm old enough to have wisdom, but I'm not yet senile. So I think many of you may be familiar with the Dunning-Kruger effect. This is basically the difference between imposter syndrome and overconfidence. And so when you start out, you're worried, you don't have a lot of experience, you're learning, and then you think you know something, and then you have a catastrophe, and then you run through the valley of despair and you move up. And if you're interested in this kind of stuff, and I'll invite everybody again, I'm happy to have you become a member of the Codman Shoulder Society, where I write about many of these things, the kinds of things that are on the periphery of what you want to know in your career development, not so much how to fix fractures or fix shoulders or whatever, but career development and navigating your these kinds of issues. And so this is just my journey in thinking about this. When I was very young, and that's me on the tricycle there, I knew nothing. And then, of course, as I moved up through my career, I thought I knew a lot until all of a sudden I had some big problems. And then I realized I knew nothing or very little. And then gradually, through critical introspection, I got better. And the difference between what you really think you know and what you actually know is what's called the confidence gap. And it's very important if we're thinking about complications, because we can avoid them if we can see the future, and the future comes from seeing the past. So I wrote 2 books on revision surgery even before reverse replacement was out there. So can you imagine what it was like trying to figure out how to revise some of the things you now do reverse with before we had reverse? And it was a real challenge. And this was part of my building my network, working with people like Christian Gerber and Joe Ionati and Evan Flato. But all of us have learning curves, and this is our learning curve from 2004 when the reverse replacement was first released. And our patients suffer for our learning curves. As you can see here, the complications that we have, and many have published this. If you want to shorten your learning curve, you have to be dedicated in practice what you do. But most importantly, you have to have a good network of expert friends, because together we help one another avoid problems. This is why you have conferences. This is why you have M&M and et cetera. And systematically, we don't always pay attention the way we should. And I've been lucky in my career to have a lot of very good friends and experts. And currently, my partner is a guy named Bassem El-Hassan, and this is from Ghostbusters, because he busts every single revision, because all he does is revision, and he does them incredibly well. If you haven't read the things that he's done, it's only because he's doing things so far ahead, he hasn't yet published it. But these are the trendsetter for how to solve major problems. So let's look at a case. This is a case one of my colleagues had. that he asked me about, and he made a video while he was doing it because it was a fracture case, and he's put in a reverse replacement. So far it looks pretty good, right? He's putting in a post, and then he impacts it down, and now he's putting in the screws, and he puts his glenosphere on, and as he turns the glenosphere, something happens, and the whole thing breaks. So how frequently does this happen, and what the hell do you do when it does happen? And so, of course, he tried to take bits of bone and pin them back together and fit things in place and rebuild the foundation for the house. Now, what happens when the foundation fails? Do you rebuild the foundation, you don't let it set, and you put the house on top of the new foundation you just built? Well, what happens is what you're going to see here, now using a screw-in base plate, which, actually Bassam came in to help with this. And the case you just saw is this. This is what it started as, and this is what it ended as. No glenoid, because everything broke and you could take virtually everything out. So how could that be avoided, and how common does it happen? And I'll try to share that with you as a jumping off point. So, if we look at outcomes and complications of primary reverse with a minimum 2-year follow-up, here's a systematic review, and you can see the complication rate. Surgical complications, 5.3%. In my book, that's pretty significant, but we accept that. We say, well, that's good. And if you look at glenoid loosening, like we just had here, that was 0.7%. So why did this happen? Well, let's look at a few other ones here. Here's another systematic review. Glenoid fractures, 0.3%, mostly with reaming, but this didn't happen with reaming. This happened with insertion of the base plate. And you can see the other complications we'll discuss in a minute. And so here's a case study demonstrating how you can put the pieces back together and fix it and have a nice post-operative x-ray, but that does not always work. And again, if this happens to you once every 300, 400, 500 cases, and you're a shoulder specialist, that's too many. So of course, we have this nice article by John Levy about alternate center line and severe bony insufficiency of the glenoid. And so that's what they tried to do in this case. And those of you who may or may not be familiar with this, basically you're putting the base plate in with a screw for immediate fixation in what's left of the glenoid, oftentimes anteverting it to do this, sometimes retroverting it. And the problem with this is that bone doesn't ingrow into a screw. It ingrows into a post. And so you get immediate fixation, but I don't know that it's always so wonderful as they make out. And in fact, when you look at it, like that nice x-ray there, then I'll get to that in a minute. Then, then you do bone grafting behind it, and because you don't have proper compression of the bone, it resorbs. So that doesn't make a lot of sense to me. Now, I was asked when I went to the OSET meeting by Kevin Plancher. I don't know if you guys know him. He's a bit of a funny fellow. He was my intern. He said, well, what if someone jumps out of a plane and they have a parachute and they break their base plate? And I thought, okay, let's consider that a stupid question. So you recognize this guy, right? He would never, have you ever parachuted? I don't think so. Anyway, so I found an article in the British Medical Journal, Parachute Used to Prevent Death and Major Trauma When Jumping from an Aircraft, a Randomized Controlled Trial. There are just some things that don't need prospective randomization. And, we can't do that kind of study for these kinds of complications. So the best you get is looking at large data sets. So I asked my colleagues, Christian Gerber and Jill Walsh, both brilliant surgeons, several questions about baseplate failure from parachuting. How common is it? Why does it happen? Is it preventable? And should someone with a reverse shoulder replacement jump out of an airplane in the first place? And so these two guys were happy to answer the first 3 questions, but not the fourth. So let me take you on a journey of my learning curve and then actually theirs. So here's a case, one of the first cases I did. This was a patient with a failed shoulder arthroplasty with severe erosion of the glenoid. And then I did a bone graft, as most of us would do. But the design of the base plates back then in the Grammont time, and in this case, I think this was a Grammont actually, but in the subsequent designs, was with a short post, right? So I did a bone graft with a lot of screws and a short post into the bone graft that I placed, which was an allograft. And guess what? That was the outcome. And so in German from Gerber and in French from Walsh, the translation is not very smart for an American, which is Gerber, because he wasn't very smart either. He had complications like this, but he has no memory for his own complications. And Walsh says that's no surprise, and you'll see why, because he had the same problems, and those problems allowed him to create another version of a base plate that doesn't have these problems usually. So I looked at my initial 4 years of data, or at least from 2015 to 2018, 236 primary reverses. And as you can see here, we had one base plate failure that was 0.4%. That's still problematic. And here's Michael Weider's learning curve for reverse. And pause for a minute and look at this. And basically, the take-home message here is it took him 40 cases for his complication rate overall to drop from 23% to 6.5%. So what about those patients in the 40 cases? How can we engineer a learning curve that's faster so that we don't have these kinds of problems? And here's our learning curve, Larry Higgins and mine, prospective study that we did from 2004 to 2011. And it's not really zero, but it dropped dramatically because of the things that we learned. So that's kind of the theme here. So here's Walsh's experience. Walsh studied 33 cases of patients who came with loose glenoids without an infection. The average delay was about 51 months, 45% reoperated on before 2 years. And in 90% of the cases, these all had errors that were avoidable. Superior tilt, base plate too high, central peg not placed in the native bone, like I just showed you, and insufficient bone stock, with no correction or no graft. And frankly, some of these cases were his. So that's something to pause about. And so here's some examples with some initial implant. This was an implant that I helped Gerber design way back when that really was not a great design. The post was short. It was very broad. I like to say it was short and wide, just like him. And, it wasn't appealing. And so what do you do when these things happen? Well, we were at a meeting and Christian Gerber said, well, can you always revise or do you ever do a resection? And David Dine said, well, do you ever do a hemi? How well does a hemi work? Well, let's look at those ideas. So in Walsh's study, he looked at what the impact of the treatment was to the outcome. And if you look here at constant score and range of motion and subjective value, look at reimplantation versus conversion to hemi versus resection arthroplasty. The patient satisfaction rate was 91% with a reimplantation, and it progressively declined. And the worst you could do is a resection arthroplasty. Now, not all these patients have pain. Some patients will have, many patients will have no pain and no function. But, it's a terrible failure if you make somebody worse. And that is a perfect example of how that can happen. And it's not just him. This is Philippe Valente, a very well-known French surgeon who showed a similar case that I'll show you here. And, this was his patient, and he uses a different type of prosthesis, which I don't think we have here in the US. But if you look carefully at the image on the far left, the base plate is high, and it's not really inclined downward. And look at its progressive failure. And you can do all sorts of nice things. You can get 3D CTs that demonstrate what things have happened, even with this long post that he puts in. Here's a revision with an inferior tilt with the base plate as low as it can go. And you can see the difference in the outcome. And people study this with expensive technology, but it's an error that you can control at time zero. So here's a case that Walsh showed to me, and this is his learning curve. So this is a patient with a severe glenoid erosion, what you might call maybe it's a B3 glenoid. That's a whole nother matter. I don't know how many of you know classification of a glenoid, but the Walsh classification describes the degree of erosions. And it's fascinating, the arguments that we have about things, because Mattson doesn't think any of that matters, which is a little crazy to me. But Gerber once told me, he said, if two people agree, one is not a surgeon. And it is a case. We argue with one another. But from that argument comes some consensus that helps you avoid these problems through these kinds of learning curves. So this was in 2003. Now, reverse was not in the United States till 2004. And this is a young Walsh visiting us. So if you look here, this is his case. Look where the post hole is with a red arrow, and look where the base plate is. And this was an individual with relatively osteopenic bone, and he missed the post hole. And paying attention to what you're doing and just lining things up, it's a little like missing a 2-foot putt. It happens, just not that often. And if it does, it's a total failure. So this was 100% controllable, and it's not like the first time I've seen that. And this is what happened 3 months later, and that was terrible. And this patient converted to a hemiarthroplasty as one of his patients that didn't want another surgery. And what he described as light pain, 3 out of 10, and active flexion to 80. I'd be surprised if it's 80, because I'll show you one. Usually they're not even that good. And this is kind of what it looks like here with the broken screws in place. So Here's another patient, severe pain 5 years after total shoulder arthroplasty, done in 2003, physical exam, limited motion, and the plan was revision to reverse with an iliac crest bone graft. They weren't using allografts so much then, and iliac crest bone grafts has its issues. So he knew now that because the base plate had a short post, he had to do something to avoid loading this. Remember what I told you about the foundation that you build a house on? And so intraoperatively, the base plate was not stable enough to be loaded with a humerus. The central peg was too short. So he initially did what is called a hemi-reverse and came back and later replaced the humerus here. And it appeared that everything was stable, except not so much. So again, and what's the message here? You want to have a post with ingrowth into the native bone, whatever you do. And if you don't, you're looking at a potential for a significant failure. So it was at that time he said, why don't we just make the post longer? And that's what he did. So that then became the Tournier implant, and that was a modification of the Grammont implant. And many of us like to use posts. Some people like to use screws. Like my partner Bassam uses a fixed screw angle device, which is with another company. Personally, I don't think that's ideal, but that's what some people want to do. But I believe in ingrowth. And so now, if you look here, and I'll talk about innovation, this problem, this question identified a problem that had to be solved and allowed for innovation to do this. And so you can deal with a cavitated bone loss like this very easily with a whole host of different devices by different companies with long posts. Most of them have taken stock in that. Augmented base plates, if you so choose, rather than having to do a bone graft. And actually, as you'll see in a moment, you can plan what you're going to do and know exactly what might work before you actually go to the operating room and try to figure it out. And so in this particular case, when I showed Gerber this in his usual fashion, he looked at me and said, it's okay for an American. And then Walsh, of course, different person, he brought me a fine bottle of wine. Taking time and understanding why are things failing and looking at cases rather than just looking at reviews, systematic reviews, allows you to think of the question and then solve with the problem. And so here's an example of two different base plates. One has ingrowth into the back, and one has a screw that makes immediate fixation. But of course, I don't actually have a conflict of interest here because I don't make any money on the base plate. But I do have a conflict of interest in terms of companies. And so I don't even know why they make a short post base plate anymore. Because if you make something like that, someone's going to use it. So let's look at some happier cases that I've known. This is a typical case that used to come in my door. Albert saw lots of these. This is a patient with a total shoulder replacement where the glenoid has failed. You see it subsided into anteversion, which makes it even worse, and there's no subscap, and there's significant glenoid erosion. So do you really want to go to the operating room and try to do this without having a plan? And would a builder build a house without an architect giving the plan first? And so one of the great innovations, and I'll talk about this in the next talk here, has been the ability to look at what you're going to do before you do it in 3D, just like an architect does. And so here's a 3D screenshot showing you, and when you subtract all the metal, that's what we have to work with. And so we know in advance, and we can go through the steps, as you'll see in a minute, how we're actually going to do the operation and what we shouldn't do. And knowing what not to do is often the key to avoiding a complication. And so if you look here, this is using a program called Blueprint. I can't hide the name because, it's hard to anonymize this. Every company has its version. I was pleased and privileged to be part of the development of this program. And look what happens. Look what's left in this particular case when we subtract the metal. And not only can I see what's left, but I can start to play around with what implants might work here. And there are other companies that have, used this to create 3D printed base plates and things of that nature. I won't use names. Right now we have 3D printing, but not for revision yet. That will be coming. But wouldn't it be nice to have the problem solved before you go into the operating room and demonstrate that that solution is reliable? Because you're setting yourself up for problems if you don't know exactly what you're going to build and what foundation you're going to have to build on. And so I'm showing you here how all these solutions don't work. or really won't work for a whole host of reasons, not just instability, but perimeter contact and inability to move the arm. And there won't be sufficient fixation in the bone for stability. In fact, AI is now going to be blended into this to give you warnings, and AI will do auto planning in order to give you optimum fixation according to what an expert would do. And you would call an expert and ask them, what would you do? And now AI will do what that person would tell you to do. And so here you can see on the humeral side what I might want to do, et cetera. And, you know, from this, we basically plan every case and try to have the fellows plan as well. And we compare before we go in the operating room. What did you plan to do? What did I plan to do? And even before you do the surgery, you learn what might be not so good and what might be good. Now, there's some confusion here. This is not predicting range of motion. This is predicting perimeter contact. So if you think that a program is going to predict range of motion, and that's a whole nother story, it doesn't, because we don't factor in kyphosis and thoracic positioning of the scapula. We don't factor in scapular mechanics. And the guy named Philip Moroder from Schulteis Clinic in Switzerland is focused on that. I'm not going to talk about that so much here. But in this particular case, I used a technique called hemi-reverse, which Walsh considered, because even with a long post, the amount of bone loss was so significant that I did not want to load the foundation I created until later. And in fact, this was a two-stage procedure. George Athwal and actually Arnaud Walsh's Gilles' son wrote about this. And because I learned from him, part of my network, I started doing it. And this was a solution. Actually, my partner did the humeral side and chose to blend this with a different implant, but didn't matter. The patient had a great outcome. And, you know, that's been durable and had remarkably good range of motion. So if you look at all of this here, sometimes you have to even go to social media to get a first look at things. And this is one of the solutions for a complex deformity with a patient-specific implant that another company makes. And this was put out there by Carl Wieser, who is the chief of shoulder surgery at the Balgries Clinic. So we don't always get things from peer-reviewed publication. So I thought, well, let me look more from 2015 to 2023 at my cases, 570 cases. And overall, I had a 1.8% revision rate, and revision for base plate was 0.18%. So I learned from the first case and didn't have any more. However, I just had one. So, you know, you think you're doing really well, and then you're hitting home runs and you strike out. And that one also was an error because I didn't put the base plate in proper positioning in terms of superinclination. At least that's what I think happened. Or the patient's older and fell down and didn't tell me. I don't know which, because it happened like 2 years later, which makes me wonder. Now, here's a big one. What about risk of vascular injury? Has anybody ever been in a shoulder arthroplasty where there's been major vascular bleeding? Major bleeding? You have. Was that with me? With Larry. Okay. Okay. All right. So good surgeons have problems. So how common is that? Well, I was appalled to see that I was part of a paper written by Neil Chen, one of my partners, on blood management and shoulder arthroplasty, 124 operations, no acute intraoperative emergencies, but average blood loss, 500 mLs. Are you kidding me? I don't know what the hell we were doing. 20% received autologous blood transfusion. When's the last time you transfused somebody? You know, remarkable what we thought was okay. And so, you know, if you look in PubMed for vascular injury and shoulder surgery, you don't find very much. What was the number here? 349 results, but it was all baloney. It wasn't anything really meaningful. So here's some articles. Avulsive axillary artery injury and reverse total shoulder arthroplasty. Actually, the first vascular injury I had was the provost at University of Pittsburgh. When I operated on him, not for an arthroplasty, he tore his subscap. He got a little bit tipsy after drinking and fell over his dishwasher door that was open and ruptured his subscap. So I put sutures in. I was doing an open repair, and I pulled on his subscap, and he had a calcified vessel. And I avulsed the anterohumeral circumflex from the wall of the axillary artery right before Jim Herndon, my chairman, walked in the room. And at that point, they were cleaning the blood off the ceiling because of the pressure that he had. And, you know, that was my first experience with vascular surgery and having a problem. Now, that wasn't arthroplasty. It was something different. But, you know, that should stick in your mind. And so here's a few more examples. Intraoperative complication during revision shoulder arthroplasty, a national joint registry data set. Vascular injury, 0.1%. 1,445 reverses, right? Here's another one, axillary artery injuries associated with proximal humerus fractures. Now, this is a key. 12 axillary artery injuries, 4%. So think about that. That is a magnitude of order higher than what we do with regular shoulder arthroplasties, even revision. So that should raise the question about should anybody be doing proximal humerus fractures in an ASC setting? And the other day, my colleague was doing that. And they called me there when he was 4 hours into the case. He wasn't bleeding, he had other issues. But as vice chair for quality and safety, and also the founder of our outpatient surgery center, said, we don't do proximal humerus fractures here. I told you this like some years ago and they forgot. So, bleeding in an ASC setting is a real problem. So what's my experience? I actually found this license plate in New York that had my name on it. So you should do more than cross your fingers. So we have a registry. Part of the Boston Shoulder Institute, which I'll briefly talk about in the next lecture, is something that I created after I went to business school because I realized, as did Codman 100 years ago, that measuring your outcomes was essential to getting better. And it made patients more confident in what you were doing. So every year we report everything we do. You can go to this website. And that's myself and Bassem, and I'm trying to get other colleagues to do it, so that we can also look at all our complications, honestly report them, know what our complication rate is, and seek to improve them. Now, what's interesting is this actually draws patients to you because transparency gives them confidence to know that you have a low complication rate, I think, compared to what I would think elsewhere. And when there's no one else to compare it to, they say, I trust you, I'll come to you. So from 2015 to 2023, the total number of surgeries I did, shoulder surgeries, is 3,624. And total shoulder, hemi, reverse are here. 1118. And if we look at the complications I had for bleeding, there were three, okay? One was arterial bleeding in the main hospital controlled by vascular surgery. This happened when a very good surgeon who already had a board certification, was part of the military, put retractors in and yanked on the axillary artery and tore it while I was finishing up in the other room. It made the front page. It wasn't in the kind of the back page. Another one was arterial bleeding, and I don't remember the specifics of that one, but again, a vascular surgeon came. And the last one was arterial bleeding that happened in the outpatient surgery center. And it just so happened that Bassem, who has training in thoracic surgery and vascular surgery and microsurgery, came and fixed it. No big deal. So that's three. That's 0.2%. Now, if that happens to me and you become an experienced shoulder surgeon, it's only a matter of time. So what will you do to avoid that? And what will you do if it happens? And so if you look at the anatomy here, and I'm sure you all read vascular and endovascular surgery journal, there are three parts to the artery as it comes underneath the clavicle. And the one where the injury typically happens is the third part, which is where it starts to become the brachial artery. It's really just the axillary artery. And it's usually associated with traction. It's rarely associated with direct injury from a sharp tool or something like that. And here's a fracture case, and this is the kind of thing that can happen, and why it's so important to recognize. If you look at this CT scan or even the X-ray before, or I think I'll show you one in a minute, you should know that there's a risk here. And if you look here, this case here, look where the shaft of the humerus is. Where is the plexus relative to that shaft? So will you just go to the operating room and treat it? No big deal. And it's particularly concerning if there's a delay in treatment, because the vessels will scar to the proximal humerus, and simply reducing it can tear the vessels. So in this particular instance, here's a CT scan. Where are the vessels located? Well, they're right where that arrow is. And frankly, here's a arteriogram that we got. And the report, the distal humeral fragment travels within 2 millimeters of the origin of the right brachial artery. Well, what did I do? I had the vascular surgeon come and do the exposure, take off the pec minor, and control all the vessels before I got there. You see all the vascular clips, and then I did the fixation, no problem. Now, what happens if you have a problem, and what did the vascular surgeon do that you should be able to do yourself? And one of the things we're going to do is create a module for surgeons working in the ASC for sure, who do arthroplasty, to, like a fire drill, go through the drill of what would you do if you had bleeding? Because if you're 12 miles outside the city like we are, it's not like you can put pressure on it and everything's going to be fine. So the first thing you do is you get proximal access. So you release the pec minor, and that gives you exposure to the plexus. And then you simply have to understand, where are the vessels? And while someone's holding pressure distally, you put vessel loops around the axillary artery and the vein, depending which you think is bleeding. And then you can take a deep breath because the patient's not going to bleed to death. Because when you have this kind of a problem, you have audible bleeding, okay? It's so fast you can't suction it out, and you don't have a cell saver. In fact, we had a patient die in the main hospital. I think you were gone, Albert, when this happened, somebody you know, who had a first rib resection for thoracic outlet. The 17-year-old girl passed away because they didn't think about the relative risk and have everything they needed available. And by the time they got it there, the patient exsanguinated. So these are important things to think about, not to scare you, but to make you aware. So having done that, now let's move on to neurologic injury, which I think you say, well, how many of you have ever seen somebody with a neurologic injury after a shoulder arthroplasty? I know Albert has. You guys got to get out a little bit, but maybe M&M, you're not showing these things, or you're not doing enough arthroplasties. So this was a study done by a group at HSS, and they did a systematic review. 188 articles, 40,000 plus patients, 510 nerve injuries, 1.3%. More common in fracture cases, axillary nerve most commonly injured. Well, what they don't tell you is what was the outcome. So we can tell you that, and I'll get to that in a minute. So this was a study done by one of our residents. I don't know if Spud was there. He probably wasn't there when you were there. He went and did a fellowship with Jay Keener at WashU after. Anyway, I got the idea to do this because one year I had fellows. It was a year after you, Albert. They were a little bit, what's the word I'm using? They made me get gray hair a little bit because they put retractors in places before I was in the room, and I was wondering, why does everybody have inability to raise their arm and the biceps doesn't work and whatever? And so they were yanking on the nerves, which is typically the case. And so we had a disproportionate number of nerve problems. And I was like really upset by it. And Neil Chen was following them, Basson was following them. And there was nothing in the literature about a large study, what happens to these patients. So Dr. Olson reviewed our 6-year experience with 923 arthroplasties. And what did we find? We found that 3.6%, 33 patients had a nerve injury. Axillary nerve, of course, was the most common. And typically it manifests as a weakness and or numbness. Now, when we followed these patients, 57%, that is 19 of the 33, fully recovered. 43% had some mild residual symptoms that were mostly numbness, some funny numbness. The recovery time was 11 to 36 weeks, and residual significant problems from the patient point of view were 0. Why is that important? Because people get sued all the time. And this now becomes evidence in support of the defense lawyer that will protect you when you have a nerve problem of a patient. When they might argue that why didn't you intervene sooner or whatever, because the literature is very clear now in a large study that these almost all get better. Now, you get EMGs and things like that, but very, very, very rare. Not a single one of these had a cut nerve. And Joe Aboud's group at Rothman Institute did nerve monitoring, which makes a lot of sense for this, because where we put retractors has a lot to do with what happens. So I'm getting a little towards the end. I think I'm ahead of time. I'm talking too fast. But what happens when things are really, really bad? And so I'll toot Bassam's horn. And one of the reasons I brought Bassam to our institution is because there was nobody in the world like him. It wasn't easy. It's very, very difficult in an academic medical center to hire a capable, qualified expert past mid-career level. They're expensive, you know. Fortunately, he was at Mayo, where these guys are not paid particularly well, and they live in a cornfield, and it's freezing cold, and you got to live underground like a Morlock most of the winter. And, you know, his family's all in Lebanon, so East Coast is closer, so we could sweeten the deal a little bit. But it's hard to get those people to come, and we mostly hire at a lower level for enthusiasm and train upward. But that experience is unique because people fly from all over the world like this patient to see him. So what about those that don't recover? This man came having had multiple failed arthroplasties with an infection and a prostholat. And as you can see here, and I don't know if the sound's going to work. Yeah, I don't want the sound to work. So as you can see here, that's his function. He can't raise his arm at all. He's got no functioning deltoid, 0. And he's got no proximal humerus. What would you guys do for this before, since I'm going ahead, before, it'll get Socratic here a little bit. We'll make this a little like paper chase. Before I show you what he did, Albert, are you the only senior person here? Can I pimp anybody else? Does anybody else do arthroplasty beside you? Or all the arthroplasty surgeons didn't come? That's okay. You can tell them what they missed. We once had a sports conference on revision of instability surgery, and almost none of the attendees came and all the fellows came. And I called the fellowship director of sports and the chief of the service, and he said, how do you feel about the fact that your fellows know better than you what to do now? Because you didn't feel you needed to come. But anyway, Albert, what would you do with this patient? Oh, yeah, but you know that that's not fair. So most people would say, I don't know. I'll do a resection arthroplasty. How would a fusion do here? Well, that's another presentation I'm not showing here, and I'm going to show another case. But actually, there are some patients that I've had that have been catastrophes like this that were miserable, and Bassam's done fusions, and it's unbelievable how well they work. Now, Joey Anati wrote about this. The average number of operations required to get a solid fusion were 3 over, I don't know, 2 years. So terrible. But you can do it if you use the right technique. You shorten the arm, and you have double plating and things of that. You put them in the spica and all of that. So Albert spilled the beans here, but basically an operation that Bassam has created, which I'm not sure if it's published yet, but which is quite remarkable, is take a look at this. This is an anatomy drawing. This is one of the things he contributed that I told him he should submit for a Kappa Delta award based on his work reanimating the shoulder. This is one of the things he's done, is use the pectoralis major and swing it over on its pedicle and make it into a deltoid. And that's exactly what he's done. And in addition, he did a reverse replacement. Now, that's a lot of surgery. How do you think that will work? I mean, you're asking a muscle to do something it doesn't normally do. And here's our patient after. Well, it's not great, but no pain, very happy, unbelievably better than what he was told from others. Oh, by the way, he also did a lower trapezius tendon transfer. That's why this guy has external rotation, because he had no cuff. And in fact, in some patients, I don't know if he did it here, use an APC and you get the graft with some of the tendon on it, and you can sew the lower trapezius directly into the tendon that comes with the graft, so you don't need an Achilles tendon as well. So this guy was in a spica cast after, and these are the kinds of results that you can get with these kinds of patients. So I didn't know how long it would take. I have a few more things to show here, and then I'm going to show you a case. This is one of my cases. This is a combination of iatrogenic fracture and revision surgery and cement extrusion. Has anybody ever seen this? Have you ever had one of these, Albert? Because you're better than me. Because this patient had a radial nerve palsy. And actually, the patient had tendon transfers and did very well. I'm not sure if this was a patient, but I got sued by one patient, and they dropped the suit because she was doing so well with her shoulder, and after a tendon transfer, she was very happy. But you shouldn't have this happen. And I know better with revisions that make an incision go all the way down, find the radial nerve and protect it. But this was a learning curve. And then this was revised. You can see that there. Now, here's a more flavorful one. Have you ever seen anything like this X-ray? This is a woman who had a knee fusion who frequently fell and had a reverse replacement using a stem that really was an ideal stem. And she didn't loosen the stem. She bent it, which is remarkable to me. And she was miserable. And so this was revised to an APC, as you see here. And she did relatively well with that. These things will happen. These are more common than what I've shown. But again, these are, things that happen. Now, this has been the basis for stem redesign and some of the things that have been done. And so we went from these long stems to now we have stemlets for anatomical, which by and large will probably avoid periprosthetic fractures that we had before. And at least with the 5-year plus follow-up we have, are at least as good as the stems we used before. And frankly, if you look at the one in the middle that has a large canal fill, you get proximal humeral resorption because of stress shielding. And the stem on the far right, which I have a conflict of interest in because I helped design, we purposely underfilled the distal canal in order to have metaphyseal ingrowth. So I would drop the mic now, but we have a little more time, and I'm going to give you an extra credit here. Does anybody know who the guy with the magnifying glass is, just because you're generational different? Somebody tell me. Do you know who that is? Right. Does anybody know who Alfred Hitchcock is? I was thinking before I retire, I'm going to make a cultural video for the next generation to understand all the great contributors in the arts that they don't know who the hell they are. People don't even know who John Wayne was, you know. So Albert Hitchcock was the greatest director to never win an Academy Award. Very interesting. Anyway, just aside. Well, when I worked in Pittsburgh, I got to see a lot of people with tattoos. And I actually did a study that I never published looking at what the tattoo was and did it correlate with the outcome. And so when people had devils and talons and skulls and things like that versus roses and Winnie the Pooh and flowers, there was a direct correlation with how well they did. And they did much better with the more gentler things than with the demons and such. And so when you're prepping a shoulder and you look at this, it should be a warning. And it was Buzz Burkhead. You probably don't know who the hell he was. He was an incredibly funny person who coined the term teeth to tattoo ratio. He worked in, he still works, he's still working in Dallas, Texas. And if the teeth to tattoo ratio is less than 1, it's a bad sign. And he founded initially the Intergalactic Institute of Shoulderology, presented at the ASES meeting. And then he renamed it the Redneck Shoulder Institute, which the short for which is RISC, which is what he said you'll take if he takes care of you. So again, the issue here is study the past if you want to define the future. And let me show you the power of follow-up. I know you might be tired, but this is extra credit. So this is a case 1 and 2, because there are a number of cases involved in this particular case. Reverse replacement can fix every problem. Myth or truth? Okay. So in 1999, this 39-year-old patient walked in my door. She had been operated on by a famous orthopedic surgeon in New York who was president of both the Academy and the ACS, so not a slouch. And in those days, they thought metal back glenoids would be good. So he put in a prosthesis that's no longer made, but it was made by Richards, which became part of Smith & Nephew, and did her total shoulder replacement. And this was a year before I saw her. She had AVN originally, and she moved to Boston, and she presented with this. She had a dislocation, it was a minor trauma. And, you know, if you look here, post-reduction, you can see something interesting. The humeral head is sitting anteriorly. And if you look carefully, it's a little hard to see on the far one there. There's some sculpting of the metal and narrowing of the joint space. There should be poly there. So let me give you some context for those of you who, I don't know when you were all born, but in 1999, Harry Potter came along. Bill Clinton was impeached. Roth IRAs were approved. SpongeBob SquarePants was popular. But we didn't have reverse replacement until 2004. So what the hell was I going to do? And, you know, I have the context to appreciate this, and this will be relevant to the talk I'm going to give next about innovation, because innovation comes from understanding the questions and the problems before you innovate. So here's the AP view. Here's the axillary view. She had increased external rotation and weak external rotation and positive belly press sign, which of course you know means subscapularis insufficiency. And the question is, what would you do? So I don't know. I don't know anybody to ask questions, but Albert, what would you do if you had no reverse? Which I had none. I know you want to get a CT scan, right? Can I give you a CT scan before you answer? So here's a CT scan. What do you think of that base plate? Is that loose? It's ingrown. That's a big problem. Metal back glenoid is ingrown. What the poly doesn't do very well, especially non-crosslink poly. So now what do I do? I better pray that this product still has inventory around. So I have a subscap failure, a poly fracture, and a well-fixed metal glenoid. So what should I do? I know what you would do. You would go in and basically take out the fractured poly and put a new poly in, right? And then you do what? You do something for the subscap. What would you do for the subscap that's gone? Yeah. Well, but you know that in retrospect, but you didn't know that at the time if it was 1999. And so the reality is, I did know, because when Bassem was working with me, and this is what Bassem looked like in well, it wasn't 1999, this was in 2000, this was subsequently we published this when he was my fellow. And basically we looked at, I don't know, 140 irreparable subscap tears, and we looked at pec major transfer, which was popularized. Pec major transfer, you know, in different settings. So isolated subscap failure, subscap, supra, and then arthroplasty. And the worst case was arthroplasty. And indeed, I did that for this patient. And this is what happened. You know, it redislocated. The subscap didn't help. Actually, I remember this well because I did the surgery. I had a fellow there looking after my patient. I went to Brazil for a meeting, and I got a phone call, it dislocated. And they said, just reduce it and I'll be back soon. No. And so now what do I do? So not to make this too Socratic, and so we can have a moment before grand rounds, I did a Latarjet, except the metal backing was problematic. And I broke the bone graft, putting it in. So what the hell now do I do? So what I did is I put anchors in, and you can see some metal anchors there, and fixed what I had of the conjoined tendon, hoping that it would act as a surrogate for the subscapularis. And the question is, how will it work and how long will it last? And that's what I'm going to show you. So here she is at 2 years post-op. Subjective value 80%, at 120 degrees of flexion. Active external rotation was 30 degrees. Still had a positive belly press sign. And here, it's her left shoulder. Here she is playing the drums. She's very happy. Okay. So now what? Here she is 8 years later, 2007. Pain is 0 to 2. Subjective value now 80%. She has a 4-year-old daughter. Active flexion 120, external rotation 20, abduction about 90 degrees. She can put her hand behind her head. Internal rotation about T10. Things are looking okay. Look at the humerus. It's a little funny looking. We'll get to that. Here's her function. Not bad. 8 years, right? What's going to happen? And we don't follow our patients, right? So here we are, 12 years. Occasional aching. Now it's up to 3 out of 10. Subjective value 80%. Still good function. If you look carefully at the axillary image, and it's hard with metal to get the right view, this poly is somewhat narrower, right? It's wearing. So what would I do now? There's no more inventory available for this implant. So future's loading. So now we're 15 years, 2014, she's 54. Now her pain level is 4 to 5. Her subjective value is 70%. Look at the cystic changes in the proximal humerus, which are probably polywear, creating an inflammatory response, resulting in loosening, which, by the way, is exactly what happens in failure of reverse replacement from the French study group that looked at 10-year follow-up. When poly wears, it's a big problem. And, you know, comes to the question of crossing polyethylene and when you should use that. But look what's happened to the poly remaining there. And I didn't have a good answer for her. So what does the future hold? Here's 2004 to 2008. You can see a comparative difference. And again, you can see the difference here. And that should be informative about metal back glenoid components, because we're seeing now more and more metal back components. And they're great, right? Until they're not great. And every metal back component that I've ever seen come to the market until now has failed and come off the market. And I won't name company names, but it's the case. And so we now have these hybrid components. You know, what happens with the hybrid components, or what will probably happen with the hybrid components, is that metal has a different modulus of elasticity than polyethylene, and the stresses will be increased in the polyethylene. And if there's not perfect contact, there'll be micromotion between the metal and the back of the poly, and they'll have fractures, which is what happened to the one on the lower right. And so this is also a warning that most people aren't heeding, because people are redeveloping these things. And I don't know what the answer is going to be. Well, I do know what the answer is going to be. I'll tell you in a moment. But it's not going to be metal back glenoid components. So 2014, 2019, subjective value now 40%, pain level 9 out of 10, 80 degrees of flexion. She's 20 years post-op. What should I do? And here's an axillary view. She's now subluxating anteriorly. You know, and if you look at the 2019 CT scan, here you can see this, okay? So what to do? So now, Arnold, we have reverse. Will you do a revision to a reverse? Will you do a resection? What will you do? Okay. What will you have available when you do it? Yeah, but they'll also be in the humerus too. Yeah. So at the time I had this, I didn't have the software program I showed you because I would have done metal subtraction to look to see what was remaining. And it would have changed what I did and what happened. But I didn't have it. And, you know, I certainly would have had an APC available because by the time you take out that stem, whether you have to split things or whatever you do, you're going to have a mess. And then the key is the glenoid. And, you know, usually the glenoids, you can deal with the glenoid, like I showed you before. But, you know, I tried to do that. And, you know, you said what most people would say. And this sign says, stay back, unstable ground. And so you plan to go on a journey, you think it's straight like this, but actually it's a little more like the one below. And when I went in and I took out the glenoid, there was virtually nothing left. I mean, it was a gigantic hole. There was zero remaining. And I would have seen that in the planning tool that I showed you before, and I would have made some alternative plans in terms of staged bone grafting, et cetera, but I didn't. And so the question is, how will she do? And here she is here in follow-up. And you can see her motion. And the reality is she has no pain. Subjective value 45% because of her limited motion. She said, I'm done. I'm very grateful you gave me 20 years. It was a great 20 years, but I don't want to go through any more gigantic operations. Now, I could show you another one, and I wouldn't have time to do that, a similar who had terrible pain. And that's one that Bassam did a fusion on. But the point is you treat the patient, not the X-ray. And she's still very grateful and very happy, and thank you very much. So what does the literature say about this, resection arthroplasty? These are all articles on this, including one that we wrote that you'll see some names there. Ruben, for example, was on that. Look at these articles. 6 of 7 patients, no pain after resection arthroplasty. 7 of 7, no pain. 13 of 18, good pain relief. All with pain relief, but average flexion 45 degrees. So you can do these sorts of things and admit defeat and have your patient live a life without pain rather than go through a gigantic, big operation, which they can go through if you have a big, you know, a big problem in terms of pain. So I'm going to finish now. You know, you probably heard this before. Wisdom comes from experience. Experience comes from bad results. You should learn from other people's experience by having a good network and reading the literature. And this is a picture of me when I first started at MGH. You think when you go from Pittsburgh to MGH, they're going to treat you well? They put a mop in my hands and said, clean the floor before the next patient comes in the room. And it's come a long way from there. So thank you very much.
I've always been very good about establishing, you know, following your patients. Have done a remarkable job doing that. What is the personnel that you need to do that? You know, to have people input.
Yeah. So I'll talk about it. You know, next talk I'm going to talk about innovations that didn't necessarily create money, but created value for patients. Because innovations are a variety of different things. And one of those innovations was Boston Shoulder Institute. And so that was bootstrapped. That cost me several $100,000 to do. The institution didn't do that because it gave me the opportunity to create education for patients on their level so they understood risks and benefit, and to do it in the context of measurement. To do measurement, I had to have research assistants. You know, when you were there, Larry had one, I had one, once we had 3. I raised a lot of money back in the days before DOJ and ABMED, when you could raise money from industry, millions actually, and I spent it all on people like Albert by sending them to Europe to see other people, and then hiring research assistants. You need human capital. You need people to do this. You need to have a measurement tool and use it on every patient. And then you need to retrospectively look at cohorts in order to determine how you're doing and grade yourself. That's the only way you get better. That's what Codman did 100 years ago. That is not the norm. We're too busy running from case to case operating to doing volume. And the expression is RVU's rule. So right now, hospitals are strapped for cash and they need volume. They need numbers to be surviving. And frankly, in the top 5 priorities of the Mass General Brigham, according to our CEO, quality and value are not the words listed. I won't say the other words. It'd be a little inflammatory. But you have, you know, I found resources and took it on myself. Unfortunately, it's very difficult to scale that if you don't have resources in your organization. I'll talk a little bit about partnership with organizations that work and don't work to achieve exactly that. And you have to show that the value you're creating is worth being supported by your institution. And the institutions have multiple missions, and you're only part of that mission.